Thank you to everyone who is joining in today to our second webinar of our 2022 sixth webinar season. We're so happy that we have Dr. Paula Rochon with us, who is presenting, and I'm certain that many of you know her name very well. My name is Joanne Murphy, and I'm chair of the RTO-ERO Foundation Board of Directors. The mission of the RTO-ERO Foundation is to invest in programs, research, and training to support healthy, active aging for all Canadians. Our activities aim to improve seniors' health care and social isolation and combat ageism. We envision a society in which all seniors live with dignity and respect. Before we get started, I'd like to deliver our land acknowledgement statement. We acknowledge, recognize, and honor the ancestral traditional territories on which we live and work, and the contributions of all Indigenous peoples to our communities and our nation. Nous reconnaissons et honorons les territoires traditionnels ancestraux sur lesquels nous vivons et travaillons, ainsi que la contribution de tous les peuples autochtones et nos communautés et à notre nation. Merci, thank you, miigwech. Today's webinar will follow our usual format. Dr. Rochon will present for about 30 to 40 minutes, and then we'll have time for questions. When we get to the discussion section after the presentation, we'll ask you to type your questions into the Q&A box, and we'll get to as many as possible. Today is the first time a Foundation webinar will include slides in both official languages, English and French. We're so excited to have added this feature to our webinars and hope that you enjoy the chance to read the information in both languages. I'd like to now introduce Dr. Paula Rochon, whose presentation today is titled Optimizing Medication Safety. I know that if you've been following the RTO-ERO Foundation, you'll be quite familiar with Dr. Rochon and her work. She's a frequent guest presenter on our webinars and also makes important contributions to the Foundation's newsletter, blogs, and other communications with our donors and RTO-ERO members. Dr. Paula Rochon is a geriatrician, founding director of Women's Age Lab, and a senior scientist at Women's College Research Institute. She is also the inaugural RTO-ERO Chair in Geriatric Medicine at the University of Toronto and is in her second term. Her research career focuses on understanding the unique needs of older adults, particularly women. She's one of the leading Canadian Health Services researchers in geriatric medicine. Dr. Rochon, thank you so much for taking time for our hectic schedule to join us today. And I will now turn the presentation over to you.
So thank you so much, Joanne, for that introduction. And I'm delighted to be here today to talk a little bit about Women's Age Lab and the idea of optimizing medications. All right, so the goals of the presentation today is I want to first provide you an overview of Women's Age Lab and talk a little bit about the progress we've made. And then I want to explore the importance of optimizing medication management. This is, such a big issue and such an important topic, so we want to focus in on that and really discuss today opportunities to put this work into practice. So I wanted to, when we think about Women's Age Lab, it's important and, kind of hard to imagine that we're actually the first and only center of its kind that's focusing on improving the lives of older women and basing that on science. When you think about the demographics out there, the fact that, in Canada, about 20% of our population will soon be over the age of 65, and the majority of those people are women, it's hard to believe that there hasn't been another research center focusing on older women in Canada or, to our knowledge, in the world. So we are the first, as far as we know. We did officially launch on October 1st. And so it's a really important center. And one thing I'll just note is that when you focus on women, you also learn a lot about men. So it's a benefit to women and men. So just to remind you a little bit about Women's Age Lab and some of our strategic objectives. One of the things that we're doing from a science perspective is science is fundamental to everything that we do. So that's kind of the foundation piece, and something that, we've always been doing work related to older adults and older women in particular. But what's different here is we're doing the idea of know, do, act. We're taking the science, and then we're taking that science and putting it into action. So we're actually finding ways to look at scalable ways that it could be applied in real life settings. And then we're doing the act part, which is really taking stories where appropriate to raise awareness about the work that we're doing. And the overall piece around here is that it'll lead to better health and social care for older women in particular. So that's kind of our strategic objectives and how we're approaching them for Women's Age Lab. Now, when we thought about Women's Age Lab, and we go from looking at aging broadly and focusing in on women, it already feels like we have a pretty important focus. But I think you could all imagine that this is still a huge area. There's just about everything that we look at. There's important differences between women and men and older and younger people that come into play. So we needed, when we were thinking about Women's Age Lab, to develop areas of focus. And so we've done that, and we've focused in on areas that really align with a lot of the work that we're doing. So one of the pieces that we're focusing on is the idea of looking here at reimagining aging in place. So just thinking differently about the way we all want to age, and also focusing in on the idea of congregate care, which is really long-term care. We are also talking about optimizing therapies and medications, which is what we're going to focus on today. And another piece that we've been spending a lot of time thinking about is the idea of promoting social connections. How do you do this in order to prevent loneliness, which is such a big issue for so many people right now, especially during COVID. So another area of our focus. And crossing through these things is the idea of gendered ageism. Why is it that women are still left out, especially older women, and aren't getting the consideration that they need? And so gendered ageism is something that we really need to address and challenge. Now, throughout the work that we're doing at Women's Age Lab, we're raising the importance of looking at data that's disaggregated by sex and age. So this is something that is important for us to think about, because by doing this, you learn not only about women relative to men, but you're looking at older people relative to younger people, and you learn a lot more information. So it becomes really valuable. So that's a key piece that we're going to talk about today as we look at medications, and just something to keep in mind in a lot of your own work and your own thinking. At the bottom here, I want to point out that the work that we're doing with Women's Age Lab is aligning with very important international initiatives. So for example, there's a global campaign right now to combat ageism, and that lines up with our work on addressing gendered ageism. We're now in the decade of healthy aging, and all of our work is talking about, how do you promote healthy aging, especially for women. So we're very lined up with that, and this is work that's being led by the WHO and the United Nations. And then of particular importance for today is this piece here around medications. And there's a major initiative out there right now on the world stage called Medication Without Harm, and we'll talk a little bit more about that in our conversation today. So that gives you a bit of a framework of Women's Age Lab, what we're doing in our priority areas. The idea that we're going to be focusing today on this issue around optimizing therapies, optimizing medications, and we will be looking at why it's so important to think about sex and age disaggregated data. So medications are certainly important. And I think we can all think of circumstances in our lives where medications have just made us feel so much better, or in some cases, they've actually been life-saving. So I think without doubt, they're incredibly important. So I think that's a starting point. But there's also, I think, room for improvement. And so our goal is really to find ways to optimize those medications, especially for older people and especially for women. And as I just mentioned, optimizing medications is getting international attention. As I did say, the WHO has identified this idea of medication without harm as the focus of their major patient safety challenge for this next little while. To sort of give you a sense of, how important this medication issue is, it was picked by the WHO as just the third such challenge that they've taken on. So their first challenge was around issues like cleanliness, and that related to hand hygiene. The second issue that they took on was related to making surgery safer, and they talked in particular about a surgical checklist. So medication safety is the next one, because that has been identified as such an important issue for us to think about worldwide. And when the WHO is approaching this, one of the sort of their key areas of sort of focus is engaging patients and the public in this discussion so that they can all have a role and contribute. And that's really what we're doing here today. We're going to be having a conversation about medications and engaging you in that conversation. So within that area of the patient safety or patient conversation, there's a couple of areas that they're focusing on as well. One is the issue of polypharmacy and reducing inappropriate polypharmacy. They also talk about high-risk situations and issues around medications of transition of care. So those are things that will come up as we talk about medications today. They certainly all fit with the idea of optimizing medications. But the one we'll probably talk about most relates to the idea of polypharmacy and how we can actually find ways to reduce polypharmacy. And I guess, when you start talking about polypharmacy, people may say, well, what do you mean by polypharmacy? Is that a number? Like what is it? And so people define it in many different ways. There's a lot of different definitions of polypharmacy. But generally speaking, it's talking about using more medicines than are necessary. And people often use a cut point of, say, 5 medications. Some people use 10 medications. So it's basically using a number of different medications, and particularly medications that you may not currently need. And it's interesting that the WHO, in terms of one of their major objectives going forward for their campaign on medications without harm, is to reduce avoidable medication-related harm by 50% globally over a 5-year time period. So pretty important piece and an aggressive goal that they're undertaking. So to speak a little bit more about medications and why they're important, we can also think about this from a financial perspective. In Canada, we spend billions of dollars on prescription medications each year. Estimates that it's over 30 billion on prescription medications. So that's a lot. Another piece that I found interesting is that when we look at our overall healthcare spending, we are actually spending about the same amount of money on medications as we are on physicians who are providing the care. And it's a large percentage of our healthcare spending. So, while, as we've said, medications are really important, there's always room to do things a little bit better. And countries around the world are thinking about this and taking this on as well. In the UK, there's an interesting report that came out within primary care that said that they thought about 10% of the prescriptions that people are getting may not still be needed in the same way. And I think when you're looking at the amount that we're spending on drug therapies, that's a large amount of prescriptions where there could be revisions, and certainly a lot of funds that are going in that regard. Also thinking about the importance of medications, and so many of these things are coming forward just right now in real time. But I know a number of you would have watched Biden give in the United States his State of the Union. And it was interesting to know that issues of importance to older people and medications were included in his comments. And they're really talking about in the United States a plan to reinforce what they're calling safeguards to reduce the use of unnecessary medications and to make sure that medications are used appropriately whenever possible, and to avoid inappropriate diagnosis and prescribing that still probably does occur. And here in Canada, it's also becoming fairly top of mind, because you would have heard also that there's talk about wanting to again pursue a national pharmacare program. And again, this is important because obviously drugs are so essential to the care that we all get. But we know that people over the age of 65 in Canada have their drugs provided. But drugs are important for everyone. And so with a national pharmacare program, hopefully the idea would be to make drugs available to everyone in the country who needs them. And also they're thinking about practical things. When you have a national program, how could it be that you can go between provinces and still get your medication? So that's really helpful for practical purposes like travel, as an example. And then obviously the thought is that if you are looking at drugs at a national level, there's an opportunity to reduce cost. So that's something that's also important. So let's look a little bit more about women and medications, and medications in our context here in Canada. So I love this visual. It talks about older people. And it's interesting to say that 2 out of 3 older people are currently getting 5 or more prescription drugs over the course of a year. And 1 in 4 are actually getting 10 or more prescription drugs over the course of a year. So those are, quite a number of people who are getting a lot of different medications. And it's also interesting to know that chronic use of what we're calling potentially inappropriate medications are highest among women, and in particular amongst older women. So this relates again to our interests at Women's Age Lab and what are some of the particular issues that are important to older women. So why might that be? So one of the reasons it might be that women relative to men are more likely to have chronic conditions and may need these medications to treat those chronic conditions. And so that may account for some of the increased medication use. But it's also older women that are more likely to be getting some inappropriate prescriptions. And so this is something where we need to pay particular attention. And also older women are more at risk for drug side effects or adverse events. And so we want to also look carefully at this when we're reviewing our medications. Now, when you're thinking about something like the work that we're doing here at Women's Age Lab, it's so important to find ways to engage people, older people, patients in this whole process. And it's important that their voices are heard and that they bring forward issues that are going to be very helpful to us as we think about our priorities going forward. And we've certainly had the opportunity to talk to patients through our focus groups done with you, the RTO-ERO. Those focus groups have been so valuable in providing all sorts of insights. And we've also been able to have interviews with older women as well. And through this, we've learned some really interesting things. One of the quotes that we got was around the issue of polypharmacy. And it says here, I only take one pill. I took 3, and I talked to my doctor into getting me off 2. I said, I really don't think I need to be taking this. And she said, I agree. So here's sort of the idea of a person who was on several medications, didn't really feel that they were helpful, went to her physician and got, had a discussion about it, was able to have a conversation and to determine what she needed to be on. And in this case, they were able to decrease some of the medications. But that's the kind of story that we do hear from people, and we have heard from people like you. So thank you for that information. Another quote that we have here, which has also been helpful, and I think also is very kind of insightful. It says we all have lots of specialists, a lot of different people kind of in the mix, having everyone on the same page is important. And I like this because it talks about, it's complicated now, in terms of prescribing. You may be getting medications from your primary care provider. You might get referred to a specialist, and there may be prescriptions coming through there that are coordinated with your primary care provider. Or perhaps you went to an emergency room and you got a script there. But there could be a variety of different people involved in that prescribing process. And so it is important, as this individual has rightfully said, to get people on the same page. I think I've mentioned that this issue about how do we improve drug prescribing isn't just one that's relevant to us here today and in the work that we're doing through Women's Age Lab, but very much an international issue. It's also one where we've had an amazing opportunity to work with an international group who share the concerns that we have about drug prescribing and are working with us to find ways to optimize prescribing. So in this particular group, we're working with people from 6 different countries. So people who are from Ireland, from Belgium, from the United States, Italy, Canada, and Israel, who all, as I say, are interested in how do they prescribe better for the older adults that they care for. And this project that we're working on allows us to come together and hear about what's similar and what's different in those different countries. So it's been incredibly valuable and a chance to really connect with people around the world. Now, as we've been saying, this project is aimed to optimize prescribing by reducing the use of inappropriate medications. But one of the unique things is we're exploring how sex differences, so biologic differences between women and men, and gender differences, the sociocultural pieces like income or poverty, or all sorts of other kinds of cultural pieces that come into play, can actually also impact prescribing, and how we can incorporate that into our thinking as we find ways to optimize prescribing. And throughout the work that we're doing with this international team, we may be using very, very different types of data, but we're in all the data that we're using, we're making a point of looking at how do we disaggregate the data by sex and age to look at commonalities and to learn more from the information that we have. And I'll illustrate this in this next piece. So here's an example of some basic data that we have related to women and men in our province, and we'll tie it into drug prescribing. So if we start looking here, this is looking at older women and men in Ontario. And at the top, you'll see that the number is about 2.5 million. So that sort of is to alert you to the fact that there's about 2.5 million people now in Ontario who are over the age of 65. That's a big number. When you look here further, the overall breakdown by women and men, you see it's not hugely different. More women than men, about 54% women. But let's look at what happens when you look across age groups. So you're going from younger, older adults, those who are 65 to 74 to people who are in the older age groups who are 85 plus and 100 plus, so people who are much, much older. You'll see that the numbers of people go down, but you'll also see that the distribution of women and men change. So when you start out at the younger age group, about 53% are women, but when you get into the older age group, about 61% are women. So just by looking at that simple demographic piece by age and by sex, we learn a lot more information than just looking at one piece alone. And let's look at this piece. And these data are coming from information that we're getting from Ontario using our provincial data sets. And here you can see what we're looking at is we're looking at sex and age differences here. So let's look, and we're looking at trying to get at some of the, what we're calling some of the pieces that relate to gender. And one of them is income. We know that women, for example, are more likely to be poor. So let's see how that kind of plays out when we're looking at different age groups. So overall, you can see here that there's a percentage of people that are considered to be poor. So that's in sort of the mid-teens. Overall, you can see it's a bit higher in women than men. So it's about 15% in men and about say 10, 11%. I'm sorry, it's about 15% in women and about 10 and 11% in men. But let's see what happens across age. So as we get from younger to older age groups, the number of people who are experiencing poverty or have low incomes increases. And you can see here, while we see in the blue bars, you see the overall numbers going up. When you look specifically at differences between women in the orange and men, you see the difference increases the most in the older age groups. So again, you can tell that when you're going here from women, earlier on, maybe having about a much lower percentage of people who are poor, in the 65-year-old age group, maybe it's in the mid-teens, and you go up here into the oldest age group, and for women, it's in the 20-odd percentage. So it really changes. So this again shows you why it's important to look at these differences. Let's look at then what happens here when you're looking at use of medications. So one of the things that's clear, and again, we're looking at overall use here, and you don't really see a huge amount of difference between women in the orange and men in terms of the numbers of medications they take. Here we're looking at, on average, people are taking maybe about 4 medications. But if we go across age groups, you see that those numbers increase. So it's lower in the 65-year-old age group and higher in those who are over the age of 85. And interestingly, when you're looking at differences between women and men, men look like they're taking a few more medications than women, but differences appear to be fairly similar in the older age group, but something that we need to explore more. And there is a thought that medication use is maybe fairly similar amongst the older age groups, but the difference is in the likelihood of developing adverse events and use of potentially inappropriate medications, and those being higher in women, older women than men. So let's just look at that a little bit more. We know some interesting examples that have been out there that have talked about adverse drug events and them being more common in women. It comes from different kinds of evidence, and sometimes it's helpful to put this information together. One piece of evidence that I thought was really interesting comes from the US, and it points to the fact that adverse drug events are more common in women than in men. And the reason this came out is they looked at drugs, prescription drugs in the United States between a period of time, 1997 and 2000, that were withdrawn from the market because of adverse events. And what they showed here is that 8 of the 10 prescription drugs that were withdrawn were drugs that had a greater impact on women than on men. So it sort of shows that these adverse drug events were particularly problematic for women, and speaks to that point. There's also an example that you might have heard of, which is widely used to talk about why we need to think about women and men separately when we think about drug prescribing relates to the example of a drug called Zolpidem, which is a sleep medication. And these medications are used primarily by women, and they're also probably more likely to be used by older women. But it was interesting that these drugs were on the market for 2 decades, being used by millions of people before data came out that showed that women were at a greater risk of having adverse events than men. And this was because they were found to be drowsier in the morning after taking the drug, and drowsy to the point that they really couldn't drive. And so this led to, after this drug being out in the market for a long time, that the decision was made that a lower dose should be available for women and recommended for women than was prescribed for men. So it speaks to the issue of women perhaps needing different doses, maybe needing lower amounts of a drug to prevent side effects. And this would be magnified for older women. So let's turn to some of the work that we have been doing that relates to getting at how can we make people aware of unnecessary prescribing and think about ways that they might want to reduce this unnecessary prescribing. So one of the pieces we've talked about have been our prescribing cascades. They're important because they contribute to overprescribing that leads to polypharmacy. And basically what it is when you're prescribing a drug, when a new medical condition develops that's misinterpreted as a drug side effect and you get another drug. This is something that I saw firsthand when working in long-term care, when people are on a lot of different medications, and you were able to see people over time and see some of these things develop that otherwise you might not necessarily see. So here's how it works. You get a drug, a new medical condition develops, and you get another drug to treat that condition because people don't connect the fact that it was potentially related to that first drug. So here's an example. You might be taking a non-steroidal anti-inflammatory drug, the kind of drug that people use a lot for pain, arthritis pain, things like that. But people may not be so aware that that drug over time could contribute to elevating blood pressure. And that could lead to a physician seeing somebody, measuring their blood pressure, thinking they have a blood pressure problem, and starting a new medication to treat the blood pressure. And that happens, or can happen fairly frequently, which means that it's very important to always think about whether that new medical condition could be related to that drug therapy. So something important to think about. And when we started looking at these, we weren't sure why they were so frequent or why we thought they might be frequent. But part of it is that these side effects develop in weeks and months. They don't happen immediately. And they're not recognized as being like a classic drug side effect. It's not like you took a drug and developed a rash and people connect the dots. They don't necessarily make the connection. And it can also be confused with age-related changes. Blood pressure is a problem that happens with age. And so it may just be thought that, it's something that's not unexpected. Our work on prescribing cascades has been talked about a lot. And it's important because it's helped people think about areas where there is potentially inappropriate prescribing. And it might be a way to help people think about reducing polypharmacy. It's been talked about in articles published in the New York Times, read by a lot of people and generating a lot of conversation. And it's in also a really interesting book called Elderhood. If you have a chance to read it, I think I've mentioned it before, written by a geriatrician, but it talks about a lot of important things around aging. And one of them is to talk about the prescribing cascades. They have a chapter describing that and how it impacts people. Just wanted to also say that we have, for our work on prescribing, received funding from the federal government to support the work that we're doing, because I think they recognize too how things like thinking about optimizing prescribing and thinking about simple pieces like prescribing cascades can help us reduce unnecessary drug prescribing, reduce polypharmacy, and help to contribute to optimizing prescribing. And important to note that the RTO ERO are working with us as collaborators and have been really important contributors in helping us to think through these projects and how to make sure that they're as relevant as possible to patients and people out there in the community. Some of the work that we've done, we've tried to find ways to make it kind of practical and useful. And so one of the pieces we wrote, which I quite liked, was 5 things to know about prescribing cascades to get people attuned to these issues. So the first thing we just talked about, a prescribing cascade, is when an adverse drug event is misinterpreted as a new condition, leading to another drug that was potentially avoidable and maybe didn't need to be added. And they can be lead to problems like people having to go to the emergency room or to the hospital. So they are important. And as we've said, they do contribute to this idea of inappropriate polypharmacy, drugs you don't necessarily need to take and maybe could be stopped. And cascades can be identified and this polypharmacy potentially prevented. Even if you think about it, you can anticipate this and prevent that problem from happening. And provides an opportunity to help people when you're thinking about which drugs are needed and maybe which drugs not so much, where to look and which drugs you want to explore further as part of that process. We've had some really interesting feedback from people like your members on things that are important. This one was good. It says, when you get older, you get given a lot of different medicines by a bunch of different doctors. And there's quite often side effects. And the one doctor doesn't know what the other doctor has given. So the 2 doctors, the side effects sort of double. And I think this speaks about how these prescribing pieces can go forward that are potentially opportunities where people can be empowered to raise questions and ask, and people can have their meds reviewed. So I thought it would be good to talk about some really practical things that you can do to help make sure that your medications and those around you are optimal. So one of the things which I think is really helpful is to always bring all of your medications and just put them in a brown paper bag and bring them all to your appointment. And it's not just those ones that are prescribed. And I think in this picture here, you'll see that these are all, kind of prescribed medications, but also those things that you buy yourself, the things you get at the drugstore, the over-the-counters, different medications like that, because they count. So you want to bring those with you to your appointment so that people are aware of what you're actually taking. And this is a piece of information that we think is really important, and it may seem really simple, but I think it's really helpful. For each drug you take or people that you are caring for take, I think it's important to know a couple of different things, just 3 pieces of information. I think it's important to know about each of the drugs, when a drug was started, why it was started, and who started it. So for example, when you think about the prescribing cascades that we talked about, if you knew the sequence of the drug prescribing, it might help to identify when it was actually a cascade. But also some of these drugs have been started many, 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 many years ago. And it's often important to continue to reevaluate. And you need to know why it was started. Was it for something really minor? Was it for a major problem? Like, what was the reason that it was started? And sometimes for these drugs that were started years ago, sometimes decades ago, people don't always remember. So it's important to have that information. And then also who started it. Was it your primary care doctor? Was it when you saw a specialist, when you were in the emergency room? Who was it that started those medications? And I think that's very, very helpful for you to know, and also for your prescribers to know as well. We also put together some questions to help patients look at their medications and even to identify things like prescribing cascades or how polypharmacy might have come forward. And I find these questions are also just helpful for conversations that you might have about your medicines. So one of the questions is, am I experiencing a symptom that could be a drug side effect? So that's a reasonable question to ask. Is there a new drug being used to treat a side effects from a drug I'm already taking? So again, something you can ask. Is a safer drug available, or could I be taking a lower dose? And this is an important question, especially over time and as people get older, where doses may need to be adjusted. And then the last question relates to, do I really need this drug at all? To go back to the beginning, we know that drugs are incredibly important, and many drugs you absolutely will always need. But in some cases, there may be other alternatives that you could explore. Things like, maybe for some mild joint problems, maybe exercise could be helpful as an example. So there's simple things that you could do in addition to your meds, or in some cases instead of your meds. But these are important questions that you might want to ask that might be helpful. Another piece to think about is it's really important to have your medications reviewed, and those for people that you might care for. And there are programs out there that you could access that might be helpful to you. So one is a meds check program, and you can work with have this coordinated, through your doctor. But it is an opportunity to sit down and just talk about your medications. It's a one-on-one interview with a pharmacist, and it's an opportunity to look at each of your medications and figure out how they work together and identify any potential side effects, and maybe give you some advice on how best to take these medications. And most important, probably it's an opportunity just to ask questions. So something that I would think is really important, and something that we would advise that you can do with your primary care provider that could be quite helpful. And, we're talking a lot about what you can do as patients, but we've also done work with our international collaborators from these 6 different countries to think about what are some guidance that we can give to physicians to help them optimize the medications that they're prescribing for their older patients. And we created this acronym. It's called DRUGS, D-R-U-G-S, and to help physicians with some of those thinking as they go through medications review and as they're working to optimize medications. So the D is to discuss the goals of care and what matters to the patients, what their priorities are. The R is to review medications. The U is to use tools and frameworks, and there's some excellent guidance out there to help look at different medications and how they can be optimized for people. The geriatric medication approach, which is you're just taking a very holistic approach to prescribing, not just focusing on a single condition, thinking about multiple conditions and how things interact. And then the last piece on this drugs piece is, in some cases, it's important to decrease doses, or even in some cases stop medications, and to sort of think about that as well. And so we've written this guidance to help prescribers internationally optimize the medications that they're prescribing for their patients. So to sort of sum up here, medications clearly have been crucial in improving our lives, just in so many different ways, and they've been life-saving as well. So they're certainly very important. But I think you've seen that the idea of reducing drug harm is a global priority. And things like the work that we're doing on optimizing prescribing, the pieces that we've brought forward internationally related to prescribing cascades, all contribute to this idea about how do we reduce unnecessary polypharmacy and unnecessary use of medications when that's needed. And really, this work is important because it raises awareness among patients and people in the community like yourselves, as well as healthcare providers, about what they might want to think about, and some of the questions that they might want to ask. So with that, I want to, of course, thank all of you for joining this webinar today. Thank you, of course, to the RTO-ERO for your ongoing support and your support of this chair that helps make this work possible. That's so valuable. And then, of course, thank you so much to my Women's Age Lab team. That it's just amazing. And they're always here to help with these presentations. They're here with me as well today. And they're, couldn't do this work without them. So thank you.
Well, thank you, Dr. Rochon. What an interesting presentation. You've offered us a lot of things to consider, especially when we go to visit our own doctors. And I was happy to see that at the very end of your presentation, you talked about tips for us as a patient, but you also presented a way for a doctor to double check and make sure that you're receiving the right medication and not really more than you should be taking. So great. Thank you. So interesting. We are going to open up the Q&A portion of the webinar now. So I remind you that we are only taking the questions that are in the Q&A box. We won't have time for all those questions, and the ones that are in the chat box will not be answered. Sorry about that. I have a question here that I would like to present. How do we address the disconnectedness in our medical system? Example, when information like drug reactions, allergies are on your record, but the next doctor or technician doesn't read it, or when 3 different doctors prescribe strong antibiotics in a short time, but no one follows up to check for related problems.
So that's a really important question. Thank you so much for raising that. But it is this idea about how I think it's been brought up in some of the quotes that were brought forward by some of the RTO-ERO members. It's this idea about there being a bit of a disconnect and people not always having the information that you might expect them to have. So we do have, electronic records, which are helpful, but we know that those systems aren't always perfect. So that's where I think one of those pieces that I was suggesting is something that you can do that can also be helpful and can add, which is, keeping track of your own medications so that, you have information about your medications and why they were started and who started them, and those sorts of bits of information can be really, really helpful. So I know that obviously there's a number of different systems in place, but I do think it's also helpful for patients to keep some of those records as well and to be very familiar with the medications that they're on.
Thank you. Here's another question that is an interesting one. Has there been discussion about how pills and drugs are presented to older patients? The packaging and instructions can be confusing for those over 85.
So again, another important question. And I think that speaks to the importance of including older people in the process of some of these different developments, because I think what you've said makes a lot of sense. This packaging is incredibly confusing. Even, for example, if you think about prescription bottles, if people are using those, it's really hard to kind of understand or even to be able to sometimes read that information. So it's not being done in necessarily a user-friendly way. And I think there's a lot that we could do to make that much easier for people to understand. Because clearly it's also important that people take the medications in the way that they're intended. And if you don't provide the instructions in a clear way, that's really difficult to do. So I think that's an important piece, and I agree with you. I don't think we've done enough in that area, but a lot more needs to be done there.
Thank you. Women in general, and older women in particular, are often treated dismissively by medical professionals. How do we address this without creating an adversarial situation?
So that gets into, I think, one of the areas that I've talked about, and one of the reasons why we've started Women's Age Lab, that often women, I guess the word has been a little bit thought of as being a bit invisible, that they haven't necessarily had the attention that they should have, and they sort of get missed out. It happens in a number of different levels. One of the things we've talked about in prior presentations is, for example, it wasn't until the 90s that women needed to be included in clinical trials in the United States. And it wasn't until, even more recently, just a couple of years ago, that older adults needed to be included in those trials. So even information about women was not readily available. So I think it's important, and that's also relates to the idea of, this idea of challenging gendered ageism, discrimination based on not only your age, but your sex. And I think we all agree that that's completely unacceptable and it impacts people's health. So, it is important for everyone, and women and all the people around them, to speak up and make sure that your voices are being heard at an individual level, but also to think about what we need to do at a community and policy type level to make sure that that's happening.
Thank you. Is the research data on prescribing cascades being used in Canadian medical schools? How is the significant information being shared with practicing family physicians?
So this information is being shared, I think, not just in Canada, but around the world. And one of the places I see it being shared is often in medication review guidance that is given out, like the piece that I showed you for that drugs guide to optimizing prescribing. Pieces like that include prescribing cascades in them. And when people are thinking about medications to deprescribe and looking at what they call deprescribing algorithms, which means what are the meds you want to target where you might want to decrease a dose, or in some cases stop the medications. In many of those algorithms that are used around the world, prescribing cascades are included. So they'll say, one of the drugs you ought to target for potentially drugs that maybe are no longer needed at the same dose, or maybe could be stopped, are drugs that are part of prescribing cascades, where a drug is being used to treat the side effect of another medication. So I think that's one way it's getting out there, but it's just good to talk about it and have people like people in the community, and in particular patients, to bring forward these issues. And that's why those questions for patients to ask are important. I think the more people bring this forward and the more people think about it, people pay attention.
Okay. Another question. I photographed the screen of questions to ask your doctor. Is it okay for me to share that on our district Facebook page?
For sure. And I think we published a number of those pieces, and I think the links to some of those publications will be made available. So yes, that's exactly the sort of information that we want to make sure people have. And I think we've tried to create some sort of pieces that are fairly, I hope, user-friendly. So if you like the way the slide looked, that's great.
Okay. How do we determine who, why, and when a drug started?
How do you determine that?
Yes.
Well, I think that's part of the thing to think about, that sometimes it's hard to remember. Like, for example, a person who, is maybe into their 80s may have been on a medication for decades, and maybe they don't remember those pieces. And, it's hard to remember that kind of information. But what I think we can do is, going forward, when a new medicine is being started, that's where I think in particular you want to start tracking that information so that you have it going forward in the future. And you can, that's helpful information to have when your medicines are being reviewed. It's really helpful for your physician to have, just at their fingertips, or the pharmacist to have, or whatever, recognizing they may also have that information, but it's important, I think it's helpful if you have it as well.
Thank you. What about supplements and vitamins? There are many supplements like D3 and calcium that are prescribed. And I was surprised that some of these things actually react to prescription drugs. You want to comment?
Yeah, I think that's really important. So it's not just these are what I call over-the-counter things, right? So, vitamins and pieces like that. And I'm sure many of us are taking different kinds of vitamins, and that's great. But there's also other kinds of medicines that people take, like, different kinds of maybe herbal medicines or other sorts of things. But it's important to know that all of these are, in essence, drugs, and they can interact. So that's why I say that brown paper bag thing is a good thing. Whatever you take, put your medicines or your over-the-counters or your alternative medicines that you're taking in that bag, and bring that as part of your discussion about your medicines, because they are interactions. And I think sometimes people think that just because you get things over the counter or they're natural, that they don't potentially also interact or potentially have side effects. So it's important to very much consider those.
In 1994, we began to test drugs on women. Is this still the case?
Yes. So women are required to be included in clinical trials now, and that's really obviously important because I think just even some of the data I was showing about demographics and pieces around drug use, there's differences between women and men, and it's really important that we are thinking about those from the outset. And there's also important differences that with age, and so that intersection of older women, older men, and these differences are really important to make sure that we're always thinking about.
Thank you. What sources do you recommend to learn about the side effects of the drug and their prevalence?
Well, I mean, a lot of people go to, Google and places like that, but I think, this is something that's really important that you want to make sure you're talking about on a regular basis when you're meeting with your primary care physician. But that's also where things like the meds check come in, because that's where you're dealing with somebody, a pharmacist or a provider, somebody who has a lot of experience with medications and can really help put it in your context. So those, I think, are some of the best resources that you can use. And that's why I brought forward the idea of meds check as well.
Thank you. Is anyone examining the way pharmaceutical companies and salespeople to physicians' office to convince them to try out new meds on their patients? I was shocked to learn that sales reps with no medical or pharmaceutical training can be the very reps meeting with physicians and convincing them to try out these new meds, including free samples to be given out.
So that's a whole different topic, another kind of area of discussion. And there has been a lot of concern about influence on prescribing from pharmaceutical companies. One of the things I'd like to note is that there's been huge efforts made to make sure that that's not happening, especially in the academic environment. So, the work that we do here is not, supported directly through that kind of approach. So everything has to be kept at an arm's length so that you're not being directly influenced by somebody saying, hey, let's just try this with your patients. So that's not happening in our environment. I recognize that's something that did happen in the past and has happened in other environments, but not in the academic environment.
Thank you. How too often drugs treat the symptoms and not the cause? Why not go to the source of the problem?
So yes, I totally agree that you want to find out what the underlying problem is as much as possible and try to manage that and treat that as much as possible. And that's why I also said that sometimes, medications may be helpful, but there may be other things that people need to think about. Maybe it relates to diet, which is so important to maintaining your health, or maybe it relates to exercise that you could be doing that's helpful. So yes, I think wherever possible, you want to go to the cause and try to address that, but sometimes you can't. And in that case, it's really important to find ways to manage the symptoms.
I believe this will be one of our last questions. Should seniors be concerned of interactions between herbal remedies and drugs prescribed by doctors?
Yes, like as I say, everything, all these different things are in fact medications, and they do have interactions. And it's really important to make sure that that information is brought to the attention of your physician and your pharmacist so that they're aware and they can potentially alert you to any potential interactions and give you advice. I mean, there's been a whole amount of research that's been done in terms of looking at some of these other forms of therapies and understanding how they work, so we know as much as possible about them. But there's a lot more that we need to learn. But yes, I think as we were saying, whatever you're taking, whether it's over the counter or other kinds of medications or prescribed medications, you need to look at all of them because they all potentially could have interactions that would be important to know about.
I'll squeeze in one more question. Why is it not possible for the information about medications prescribed by other health providers to be shared with your primary health provider?
So I think it is shared, and for the most part, that information is there. But sometimes it just maybe isn't sort of readily at hand, or for example, maybe you're not going back to your primary care physician, you're in an emergency room somewhere or some other setting, and it may not be as accessible as you'd like. So yes, that information is something your primary care doctor collects, and they do have that information. And of course, they should have that information, but I still think it's also important for you as the patient to know the medicines that you're on and to have that information available as well.
Well, Dr. Rochon, thank you so much. This has been such an interesting presentation and great questions. I'm sorry we couldn't answer them all today, but I believe that Deanna is making a list of them, and I'm not sure what will happen after that. But thank you to all of the people who joined in today and to those of you who sent questions that Dr. Rochon answered. And I hope that you remember the foundation is always here. If you would like to support the foundation, you can reach us by phone or mail, which you're going to see on the screen any minute now, or you can visit us online to get more information about our work or to make a donation. I want to mention to everyone in attendance that a very short survey will pop up on your screen as soon as this webinar ends. Your feedback is very important to us, so please take just 1 minute to let us know how we did today. Again, from all in attendance today and from the RTO-ERO Foundation, we want to express our sincere thanks to Dr. Paula Rochon for taking the time to share this excellent presentation and answer questions. Dr. Rochon, is there anything you'd like to add before we finish?
No, I just want to say thank you so much. And thank you so much to the RTO-ERO and all of your members who helped so much and contributed so much to the work that we're doing. It's a pleasure to be able to present today. Thank you.
Well, thank you. This concludes our webinar from the RTO-ERO Foundation and our guest, Dr. Paula Rochon. Thank you again, everyone, and please stay healthy and safe. Stay tuned for the third webinar in a few weeks. Goodbye.